Metformin mechanism of action is activation of AMP activated protein kinase. It increases the insulin sensitivity, decreases liver gluconeogenesis, may also decrease GIT absorption of carbs. Adverse effect: GIT upsets are common, decreases vitamin B12 absorption, lactic acidosis with severe liver disease and renal failure. Contraindications in CKD: review if the creatinine is more than 130. Stop if it is more than 150 and eGFR is less than 30. Iodine contrast media: discontinue on day of procedure and for 48 hours thereafter. Alcohol abuse in is relative contraindicated. Metformin titrated slowly before increasing dose, at least 1 week. Teratogens, ACE inhibitors: alcohol, aminoglycoside, carbamazepine, chloramphenicol, cocaine. DES, lithium, maternal diabetes mellitus के causes हैं ये. Smoking, tetracycline, thalidomide, valproate and warfarin. So ACE inhibitors will cause renal dysgenesis, craniofacial abnormality. Alcohol will cause the same thing. Aminoglycosides will cause ototoxicity. Carbamazepine will cause neural tube defect, craniofacial abnormality. Chloramphenicol will cause grey baby syndrome. Cocaine causes intrauterine growth retardation, preterm labor. DES will cause vaginal clear cell adenocarcinoma. Lithium causes Epstein's anomaly. Maternal diabetes mellitus will cause macrosomia, neural tube defects, polyhydramnias, preterm labor, caudal regression syndrome. Smoking, preterm labor, IOGR. Tetracyclines cause discoloration of teeth. Thalidomide will cause limb reduction defects. Valproate again will cause neural tube defects, craniofacial abnormalities. Warfarin will also cause craniofacial abnormalities. Paracetamol overdose risk factor is for hepatotoxicity. Liver enzyme inducing drugs like rifampicin, phenytoin, carbamazepine, chronic alcohol excessive, St. John's wort, malnourished patients, acute alcohol intake as opposed to chronic alcohol excess, metabolic pathways, liver conjugates PCM with glucouronic acid or sulfate. During an overdose, conjugate becomes saturated, leading to oxidation by P450 mixed function oxidases. This cause glutathione is something which conjugates with N-acetyl B-benzoquinone imine, which is a toxic metabolite, and converts it into mercaptouric, which is toxic. So how will this work in paracetamol poisoning? N-acetylcysteine, which is a precursor, this will increase the liver glutathione production. Okay? And that is why it will bind to this toxic metabolite and convert it into a non-toxic metabolite. Clinical picture: if the patient comes within 8 to 24 hours, then you can give acetylcysteine. Liver transplantation, you have the Skring's criteria, wherein the arterial pH should be less than 7.3 24 hours after ingestion, or the prothrombin time more than 100 seconds, creatinine more than, I think this is 10 seconds, 300 micromole per liter, grade 3 or 4 encephalopathy. Pharmacokinetics: phase 1 reactions are oxidation, reduction, hydrolysis. P450 enzymes, alcohol dehydrogenase, xanthine oxidase. Product more active and potentially toxic after phase 1 reactions. phase 2 reaction में mainly conjugation होता है. The product is inactive and excreted in urine and bile. All this and the enzymes involved are glucouronyl, acetyl, methyl and sulfate, and all this will lead to decrease in the lipid solubility of the medicine. First pass metabolism: aspirin, isosorbide dinitrate, GTN, lignocaine, propranolol, verapamil, isoprenaline, testosterone, hydrocortisone. Zero order kinetics: phenytoin, salicylates, heparin, ethanol. Acetylator states 50% deficiency in hepatic N-acetyltransferase, isoniazid, procanamide, hydrolysin, dapsone, and sulfasalazine. Dopamine receptor agonist indication: Parkinsonism disease, prolactinoma and galactorrhea, cyclical breast disease, acromegaly, pergolide, bromocriptine, cabergoline, ropinirole, apomorphine. Pergolide, bromocriptine and cabergoline, this will cause lung, retroperitoneal fibrosis, lung fibrosis and heart fibrosis. Ropinirole and apomorphine, these are will not cause these. So these are safe. These will not cause fibrosis. Adverse effect of dopamine receptor agonists are nausea, vomiting, postural hypotension, hallucination, daytime somnolence. Immunoglobulins. What are the indications for immunoglobulin? Primary and secondary immunodeficiency, idiopathic thrombocytopenic purpura, myasthenia gravis, Guillain-Barré syndrome, Kawasaki disease, toxic epidermal necrolysis, CMV pneumonitis, especially after kidney transplant, decrease in the serum immunoglobulin G due to bone marrow transplant, dermatomyositis, CIDP. These are formed from large pool of donors, immunoglobulin G molecules with a subclass distribution. T half is 3 weeks. Anti-anginal side effects of CCB, beta blocker, nitrates and nicorandil. CCB will cause headache, flushing, ankle edema. Ankle edema is something which is asked in exam. Verapamil will cause constipation. Beta blocker, very important. Bronchospasm, fatigue, cold peripheries and sleep disturbance. It is contraindicated in psoriasis as it may exacerbate those symptoms. Nitrates, headache, postural hypotension and tachycardia. निकोरांडल में headache, flushing, anal ulceration होता है. Combined oral contraceptive, these increase risk of breast cancer, cervical cancer and decrease the risk of ovarian and endometrial cancer. Advantages: make period regular, lighter and less painful. They decrease the risk of ovarian and endometrial cancer and colorectal cancer. They protect from pelvic inflammatory disease, decrease ovarian cyst, benign breast disease, acne vulgaris. Disadvantage: they increase risk of venous thromboembolism, increase breast cancer, cervical cancer, stroke, ischemic heart disease, headache, nausea and breast infection. Aspirin will block cyclooxygenase 1 and 2. Lithium toxicity: it will be precipitated with in case of dehydration, renal failure and drugs like diuretic, especially thiazide, ACE inhibitors, ARB, NSAIDs and metronidazole. The therapeutic range is 0.4 to 1 millimoles per liter. Toxicity is more than 1.5. Clinical features: cause tremors, hyperreflexia, acute confusion, polyuria, seizure and coma. Management: hemodialysis, severe toxicity, sodium bicarb. Acute intermittent porphyria, the drugs are autosomal dominant, porphobilinogen deaminase defect. Abdominal neuropsychiatry, most common in females. Precipitate attack, barbiturate, benzodiazepine, halothane, alcohol, CP and sulfonamide. The drugs which are safe in EIP: PCP, aspirin, codeine, morphine, chlorpromazine, beta blocker, penicillin and metformin. Drug causing urticaria are aspirin, penicillin, NSAIDs and opiates. Amiodarone and thyroid gland. Amiodarone induced hypothyroidism, high iodine content, Wolff-Chaikoff effect. Amiodarone induced thyrotoxicity are two types, AID type 1 and AID type 2. In type 1, there is an excessive iodine induced thyroid hormone synthesis and there will be goiter. You will manage it with carbamazepine, potassium perchlorate. Type 2 there will be destructive thyroiditis. There is no goiter and it should be managed with the help of corticosteroids. Quinolones, these inhibit DNA synthesis and bactericidal nature. Ciprofloxacin, this might cause G6PD, levofloxacin. Mechanism of action of quinolone: it will inhibit the topoisomerase 2 DNA gyrase and topoisomerase 4. Resistance will be caused by mutation to DNA gyrase, efflux pumps with the decrease in the intracellular quinolones cone. Adverse effect: decrease seizure threshold, tendon damage, cartilage damage, lengthens QT interval, contraindicated in pregnant, breastfeeding, and avoid in G6PD. Adrenoreceptors, these are alpha 1, alpha 2, beta 1, beta 2, beta 3, and there are dopamine also. So here alpha 1 is vasoconstrictive. It will cause relaxation of the GI smooth muscle. It will cause salivary secretion, hepatic glycogenolysis. Alpha 2 is presynaptic and it inhibits neurotransmitters. It inhibits insulin and platelet aggregation. Beta 1, it affects heart. It increases heart rate and the force of contraction. Beta 2 will cause vasodilation, bronchial dilation, relaxation of GI smooth muscle. Beta 3 will cause lipolysis. Pathways: G protein coupled receptors. Alpha 1 will activate phospholipase C, IP3 and DAG. Alpha 2 inhibit adenyl cyclase. Beta 1, beta 2, beta 3 will stimulate adenyl cyclase. Adrenoceptors antagonist. These are alpha antagonist. Alpha 1 antagonist is doxazosine. Alpha 1A is tamsulosin, mainly on the urogenital tract. Alpha 2 antagonist is yohimbine. Non-selective phenoxybenzamine. Beta antagonists are beta 1 and atenolol. Non-selective is propanolol. These are the ones which are asked in exams. Carvedilol and labetalol are mixed alpha and beta antagonist. Therapeutic drug monitoring: lithium 0.4 to 1 millimole per liter, take 12 hours post dose. Cyclosporine, trough levels immediately before the dose. Digoxin, at least 6 hours post dose. Phenytoin, before next dose, only adjustment is suspected. Only when adjustment and when you're suspecting there should be some decrease in the dose. Methanol poisoning: there is accumulation of formic acid, macular edema, optic neuropathy, blindness. Management: fomepazoles cofactor, folinic acid, decrease in the ophthalmological complication. Drug acting on common receptors, agonist and antagonist. So alpha 1 is decongestants, phenylephrine and oxymetazoline. Alpha 1 antagonist will be useful for BPH like tamsulosin, and for hypertension like doxazosine. Alpha 2 will be for glaucoma, topical brimonidine. Beta 1 inotropic, dobutamine. Non-selective and selective beta blocker, atenolol and bisoprolol. Beta 2 agonists are bronchodilators like salbutamol. Beta 2 antagonists are propanolol and labetalol. Dopamine agonists are useful in Parkinsonism disease, ropinirole and prolactinoma. Dopamine antagonists are used in schizophrenia like antipsychotics. These are haloperidol and antiemetics. GABA agonists are benzodiazepine, baclofen, and GABA antagonists are flumazenil. Histamine 1 and histamine 2 antihistamine, loratadine, and antacids are ranitidine antagonist. H1 antagonist is loratadine. H2 antagonist is ranitidine. Muscarinic glaucoma, pilocarpine, atropine, bradycardia, bronchodilator, ipratropium, tiotropium, urge incontinence, oxybutyrin. Nicotinic, nicotine, varenicline, depolarizing muscle relaxant, suxamethonium, non-depolarizing muscle relaxant, atracurium. Oxytocin inducing laborer syntocinon, tocolysis, atosiban. Serotonin triptans, acute migraine, zolmitriptan, antiemetic, ondansetron. Overdose management. Okay, so I'll just read this again. Muscarinic glaucoma, muscarinic agonist glaucoma के लिए we use pilocarpine. Muscarinic antagonist atropine for bradycardia, bronchodilation के लिए ipratropium and tiotropium, urge incontinence के लिए oxybutynin. So this is muscarinic antagonist. Nicotinic agonist is nicotine, varenicline, depolarizing muscle relaxant, succinylmethonium. ठीक है. Nicotinic antagonist is non-depolarizing muscle relaxant, atracurium. Oxytocin agonist inducing liberal syntocinon. Oxytocin antagonist tocolysis ertosiban. Serotonin triptans acute migraine, zolmitriptan. Serotonin antagonists antiemetics and ondansetron. Overdose management, paracetamol, activated charcoal less than 1 hour, and acetylcholine, liver transplantation. Salicylate urinary alkalinization with IV bicarb.